Good morning and welcome to the London Ambulance Service meeting in public. Present with me today in the room are the board members, executive and non-executive. Online we have one of our non-executive directors, Dr. Mark Spencer, to join us. Two non-execs still to arrive, and absent today due to annual leave is Anne Rainsbury, non-exec director. Welcome to members of the public joining us on the live link. Are there any declarations of interest that we need to record at this stage? I'll take that as a no, thank you. So if we could take the minutes from the meeting on the 27th of July, please, and I ask, are there any points of correction? On page 1, there are 11 pages of this. So page 2, page 3, page 4, page 5, page 6, page 7, page 8, page 9, page 10, page 11. Can I therefore sign those as a correct record of the meeting? Yep, thank you. So before we go any further, what I'd like to do is to welcome our new incoming Chief Executive, Daniel Elkeles, to his first meeting. He has been in the Trust for about 6 weeks now, getting to know everybody, but it is his first formal meeting and we will be hearing from him later on. Thank you. We have some actions arising from the previous Trust Board meeting, an action log, so just going through those. Kadir, I think this is yours, isn't it? And between you and Daniel may want to answer this tricky one on the NHS 111 service. We're picking that up in the private part, is that right?
Thank you, Chair. We're picking this up in the private part with an update on our current service provision of 111 services and next steps, including the work commissioned here.
Okay, thank you. And the digital scorecard, that's work in progress. Can I just ask who will be the lead? Fenella, it's got your name down, is that correct?
No, it's Barry.
Pardon?
Barry.
Oh, it's Barry, so I don't know why it's got owner Fenella.
I think it was clinical digital scorecard.
Clinical digital scorecard.
But I'm here as well as, it says in consultation with the chair of the LIC, so I'm not quite sure of that action.
Daniel?
So we discussed it yesterday. I think Barry thinks he's working with you, Sheila.
Oh, okay.
So can we just revise that then, say it's Barry working with Sheila?
All right.
And so is it clinical or is it not clinical?
Well,
So it's capturing a range of different metrics. So John and I will support from the clinical and quality metrics so that we broaden out the scorecard that's been developed through the IPR to be able to capture some of the other metrics that indicate the quality of care that we're providing.
Excellent. So I think, James, the action for that one is that it changes its owner to Barry, working with the chair of LIC, Sheila, but with input from a medical point of view from both Fenella and John. And are we still content that that comes back 30th of November?
Yes, it's being worked on.
Yeah, I'll follow up with Barry.
Great. Thank you,
meeting.
Sheila. Thank you. The change management, I think we have changed that one, have we not? This is the Andrew Goodman coming to talk about the work they've done.
So we thought we'd focus the development session in October on people in general, of which
Yes.
this would be a specific.
Okay, that's helpful, thank you. CIPs, that dreadful term to
Cost
be called
improvement
waste
programmes,
reduction.
yes.
Sorry, Lorraine?
It's incorporated from month 5.
Thank you. Good. Staff absence levels. So that's not due yet, but Damien, you're the owner of that.
Yeah, and myself and Anne have met, and we've got a downward trajectory to 6% by March, reflecting the enormous pressure at the moment.
Yes, it's a real challenge, but a very important piece of work. Thank you very much. Okay, so that takes us on then to the main agenda, starting with my report. And clearly, I think the most two very important things here is our incoming Chief Exec and welcoming him. And he has spent an impressive amount of time getting to know the service, meeting staff in all aspects of it to help him form a view, and working closely with Kadir to pick up all the things we know from Kadir who sadly departs at the end of this week. So it's a really important transition period of time. And as we are delighted to see our new Chief Exec come in, we are sorry to see Kadir going, but he's promised to keep in touch. And we were talking this morning about his perceptions of 2 years ago and now. And I think it is true that he has galvanised the coup leadership team and made developments and talent in his parts. A big, big portfolio he's had, pioneered new innovations and supported genuine blue light collaboration with our colleagues in the MPS and London Fire Brigade. So we need to continue with those things. So much appreciated, and we will miss you. Thank you. It's been difficult in COVID for the board members to get out and about, but at the end of last month, with our departing Chief Exec, Garrett Emerson, the board did go and visit a number of sites, particularly the new logistics packing site, the medicines management, and this site, this fantastic site. We are today in Newham, in a building where one of our new education centres is sited, and one of our emergency operations centres will shortly be here too, moving from Bow. So we're thrilled to be here today, actually, and delighted to see such a good education centre. So it was good to be out and about. We need to do more of it, and that will be our plan going forward. And an important meeting that Daniel and I had with Lord Toby Harris. Lord Toby Harris has had a lot to do with writing reports and reviewing resilience of the capital, and he has been commissioned by the Mayor to do another review, given the risk of cybersecurity and other attacks in the capital. We were able to assure him that the actions arising out of London Bridge and the other events of the last few years have occurred, and that there is good working between the London Fire Brigade and the Metropolitan Police. And it was, I think, helpful to be able to have input to his next report, and we wait to see what that says. But things like assuring him we had sufficient people working in heart that were fully trained and tactical response, that the telephony issues were being addressed, was good to do and good to have ongoing input into those reviews. So I'm going to leave that there. I haven't put too much there, and take, I think, if we can note that. If there are no questions on that? No. Let us move to then Daniel as Chief Exec, his first report.
Thank you, Heather. So firstly, I'm delighted to be here. I've had a very warm welcome. Thank you very much. So as you've already remarked, it's Kadir's almost last day. Am I allowed to tell everyone what the arrangements are?
Yes, of course you can.
Going forward. So I'm really pleased to say that the Deputy Chief Exec portfolio will be jointly held by Fenella and John as our Chief Paramedic and Chief Medical Officer. So they'll be the Deputy Chief Executives from Monday. And they will cover the operations brief that was in Kadir's portfolio. And then Kadir leaves a place on the board for a voting board member from the exec side, and I'm really pleased to say that Damien, our Director of People and HR, will take up that post, because we really got to focus on people and culture. So that feels very important too. And there are lots more changes coming too, but those are the key ones for now.
That's great. Thank you.
So then onto the main body of the report. I have to start in a sad place, which is for us all to express our condolences to the family of Orin and the family of Debbie, both of whom have passed away since the last time the board met. They're both really valued members of staff. Debbie was a volunteer and Orin worked in the Make Ready service. In my report, I've got lots of photos of the places I've been. I'd like to say I've been everywhere. This service is enormous. And I think I've only been to about a third of the places that we operate from in the first few weeks. So South East London is getting my full attention tomorrow and on Monday. Then there's a section in the report about I'm really pleased that we have opened, or in the process now of opening, many of the ambulance stations that we weren't able to operate on with during COVID. And there's a big positive reaction from staff to doing that. And then lastly, this is an amazing institution. The number of awards that our teams have picked up in the last few weeks mainly from the HSJ, but also from NHS providers, and the NHS Confederation is huge, and we've listed them all. I'm joining a service that should be really rightly proud of the clinical quality that its team deliver. I think that's sufficient.
Did you want to mention South West London 111, or is that coming up later?
It's in Kadir's
Okay,
Chief Operating
fine.
Officer's report, so I
That's
thought we'd just
fine.
do it then.
Okay, thank you. Any questions to Daniel? No.
Just a big welcome, Daniel.
How
It's great
nice,
to have you.
Sheila. Indeed, welcome. And I've already welcomed Mark online. I think Jill, I failed to say Jill was joining us online as well as Associate Non-Exec, so welcome too. Thank you.
Thank you.
Okay, moving on then to the report of the last report from our Chief Operating Officer.
Thank you, Chair. So just, I'll take the report as read and happy to take any questions, but just really, as it is my final report, just to take the opportunity to recognise the immense achievements of colleagues across the organisation. Really, I'm only a figurehead, so just to recognise everybody's collective effort over the last couple of years that I've had the privilege to be the Chief Operating Officer and the Deputy Chief Exec of the London Ambulance Service. There's a huge amount of work that's been done, and hopefully I've captured some of that in terms of the latest progress that we've made in those areas. But recognise there's a huge amount of work still to do. Just a couple of points in the report it's worth recognising that based on the national ambulance data for August, the LAS performance in the context of the wider challenges that the ambulance sector and the urgent and emergency care sector is facing, we remained the top performing ambulance service for our Category 1 response times. So our ability to respond to our sickest patients in relation to Category 1, we for August, were the top performing trust across the country. In relation to Category 2, which includes a still very sick patients, as a trust, we saw the second highest proportion of Category 2 patients across the English ambulance services. But even within that context, we still remained above average in terms of above the average level of Category 2 response times. If I pause there, and happy to take questions and context, there's probably a lot in the report, but happy to take any questions.
So when we look at our board reports, we're always a little bit in arrears, and I think it's important to recognise, certainly for the members of the public joining us, that all ambulance trusts across the country have been dealing with unprecedented demand for the whole of the summer. And this has put incredible pressure on our services and our staff to be able to provide the level of care that we would like. It really is very challenged to meet Category 2 patients in particular, and a lot of work is going on to make it as safe as possible. And it is recognised nationally by our leaders. Any questions for Kadir at this point?
Just to add to that, Chair, as I've referenced in the report, the 3 summer months of this year, 2021, were all in the top 5 busiest months in the Trust's history. Yeah. Normally, these would be in any annual cycle the 3 quietest months. So just to reinforce that extraordinary level of patient demand that we've seen.
Thank you. Any other points people would like to?
Heather, yeah, I've got a question.
Yes, Jill.
Yeah, no, thank you very much, Chair. I just wonder if you can shed a little bit more light on the demand. At the last board meeting, you talked about there being 3 drivers of the demand, some of it being COVID, some of it being change in behaviours of patients, and some of it to do with sort of a catch-up of people with serious illnesses from pre-COVID. And I just wondered if those are still the same drivers of the demand. And I think when we come on to the integrated performance report, are we going to talk a little bit more about how we're going to manage Category 2s going forward?
Thank you, Jill. Just in terms of those 3 areas, I think the first point is, I think we've certainly seen, and perhaps Damien and could elaborate on this, but we've certainly seen some of the highest levels of annual leave in the Trust's history during the month of August, and that's that's rightly colleagues across the organisation taking a huge amount of annual leave that's just not been taken during the pandemic. So some of the highest levels of annual leave in August taken in the Trust's history, rightly so really in terms of health and well-being. Demand, as you say, Jill, has been extraordinarily high, and so that continues to be a driver. But as we've come into September, certainly as children have gone back to school and those summer months have concluded, our resourcing and our ability to meet that demand, so demand's come down, and our resourcing and our ability to meet that demand has increased. And we've also seen, and again, Daniel may want to elaborate on this, a reduction in the levels of sickness and isolations that we were experiencing during June, July and August. So those three things, recognising that the report is retrospective, if we take those three things in September, each one is improving. Demand has eased, sickness levels have reduced, and annual leave has also reduced as colleagues across the organisation have been able to take significant levels of built-up annual leave. So as we come into September, you will see an improving operationally performance position and our ability to meet our response times.
Possibly offset by flu. I wonder if Fenella would like to say something at this point as our medical director.
So we are certainly seeing an increase in respiratory illness across all age groups, but in particular children and school age, and then the over 60s. Interestingly, from a COVID point of view, however, the patients that are being admitted to hospital are falling into the 20 to 40-year-old bracket primarily. So the vaccination programme that's ongoing for COVID is absolutely critical to be able to maintain safety. And as we go into the influenza season, the rollout of the flu vaccine for all eligible patients and healthcare workers, social care workers in particular, will help us to minimise impact on them. Remembering that last year we virtually had no influenza at all because of isolation and lockdown, and also the enhanced infection prevention control measures that were across the whole of England. So mask wearing was mandated at that point in public places. So we have a very active flu campaign already starting, which Damien will touch on in his report, but also maintaining the healthcare guidance on social wearing masks when we're moving around buildings and such like.
Thank you. And it is something that's the focus of the whole country the health service of trying to plan. And also evidences why it's so important that we work with our partners, all the other providers and our integrated care systems to try and resolve this for the public, because it is a national problem that we are all facing. But thank you for that. Amit.
Just following up on that, Chair, I know we talk in the report about potentially seeing the highest level of demand that we've faced in the winter if a number of factors come together, and they may not come together. But I'm just wondering, what are we doing in terms of scenario planning for almost a worst case scenario of demand?
Yeah, it's a good point, Amit, and it's something that we're currently working through. So as an executive, we were only talking yesterday about what we anticipate the winter to look like, and whether at the moment there's a lot of discussion about this winter being incredibly challenging. I think what we need to get into and drill down into what are those indicators that suggest it will, and how will we respond to that. Daniel has commissioned a piece of work that we've been doing in terms of developing our at the last board. I talked about our kind of 8 priority areas. We've progressed from the last board to this board, progress in relation to those 8 priority areas and additional actions, which essentially will form our winter plan. And I think for the November board, it's probably worth bringing the winter plan here for assurance.
And for members of the public, of course, it's also the 111 services that we run, and the incredible demand on primary care.
Yeah.
So it is complex. Daniel, do you want to add at that point? No? Okay, so we will bring back to November, but it's a good question, Amit, and we do need the scenarios. Thank you. So that takes us then to our integrated performance report, where we report on quality and clinical care first, people and culture second, and then finance and audit. And what we aim to do is to hear from the executive, and then where there's been an assurance meeting, the non-execs report on their area as well. So starting with quality and clinical, you've got the integrated report is available in the papers online, and for people to have asked, so you can ask questions in advance or indeed online. I'll turn to you then, I think, John, at this stage.
Yeah, thank you, Heather, and good morning, everybody. So 2 reports in the pack today from myself. So the first is in relation to our quality priorities. So these are the 10 quality priorities we set at the beginning of the year in our quality account, and the paper provides an update on them at the end of Q1. We're obviously rapidly heading towards the end of Q2. Against those 10 priorities, the first one was the patient safety incident response framework. That's now in place and operational across the trust. Second relates to integrated urgent care staffing. Kadir just picked up the ongoing review in relation to that. Clinical equipment was the third one. We're making good progress on that. More to do, as you'll see, in terms of the incidents within the report. Number 4 was around medicine storage. We've again made good progress on that, including temperature monitoring, and the board had a visit to the new medicine packing unit, which opens imminently. Number 5 was related to community involvement, and we've got an update coming from Anthony later on in the meeting in terms of our staff and patient council and how that operates. 6 was a clinical strategy led by Fenella's team, which is on track and progressing well. 7 was related to joining together the 2 CASs for 999 and the 111 service. So CAS is a clinical assessment service. We are seeing good progress. You'll see that in the paper in relation to our hear and treat rates. Number 8 is station accreditation. That is unfortunately on pause at the moment due to the level of demand, but we are looking to see if we can adapt that whilst not losing the work that Tricia Bain undertook. 9 is cultural diversity and inclusion strategy. Again, we are ranking that as on track. And number 10 relates to health and wellbeing. So a reminder of the 10 priorities, which we'll hear again at our annual public meeting later. I'll pause at that point before going on to my second report to see if there's any questions in relation to where we're up against those priorities at this stage of the year.
Thank you, John. Are there any questions for John at this stage?
I have one, John. Just on the, I think it was number 2. You mentioned that obviously this is the first quarter, but do you have any stats for the second quarter? Just in terms of whether we're seeing some improvements in the number of incidents related to medical equipment failures, etc. Because I mean, it looks like from baseline to Q1, we're pretty much static.
Yeah, so you're right, the Q4 and Q1 is static. We haven't got the Q2 data yet because that's about to finish out. We do expect that clinical equipment, if you look at the datix, is that the incidents that are coming in, that we do continue to see them. That's why we've pursued this bit of work about changing the asset management, the storage, how do we service them. So I would suspect it's more likely to be the latter end of the year, Q3, 4, that we see the number of incidents reported by our staff coming in for medical equipment.
But this is very important, isn't it? Because it's about our staff having the right tools of the trade to be able to make the clinical assessment. So it's frustrating for them and it's not the best for patient care. So we really do need to get a trajectory, get it down. But there is a plan in place. It's going to take a little while to implement. But we need to start, end the year with a system in place so it's not what we're seeing next year. Yes?
Yeah.
Good. And I just want to comment, Fenella, perhaps, that we do have a clinical strategy. This is a refresh of the clinical strategy, isn't it?
So the actions are against the refresh clinical strategy that was signed off just prior to COVID.
Which seems a long time ago.
Which seems a long time ago, but we've still made progress, and COVID has actually been an enabler for many of the integration with the wider system for us to be able to move things forward that may have taken a little bit longer had we not had the support and momentum behind with stakeholders.
And for those members of the public joining our APM later, there are examples, little vignettes of that, of some of our collaboration in the system that we will be showing you. So thank you, Fenella. Anything else for Fenella or John at that stage on that?
I had a question on point
Please.
9, so the culture, diversity, and inclusion strategy, obviously really important, where you mentioned a further update will be available in September. It would be great to see the concrete roadmap and next steps, because it's
That-
such a hot topic.
Probably goes to Damien, doesn't it?
It does.
Yeah, I think what I can do is update in the next board report, because we've
Yep.
done a bit of work and bringing in some extra support, but as we're retrospectively reporting, I haven't included it in this report.
All right,
Will do.
great.
Thank you. Bob?
Thank you, Chair. If I look at the overview dashboard, the only issue that's showing amber is the issue on medicine management, and then when I tuck into the underpinning KPIs, there's one issue around the 100% rollout of inventory management slipped to September and October. So given the fact that we're almost at the end of September, is that going to go green? Is the first question. And the second piece is, could you just say something about the update of pharmacy recruitment, please?
Okay, so 2 good questions there. Are we going to go green on medicines management?
Okay, so the Medicines Management Improvement Programme is a programme that's been in place since 2016-17, when we had our initial CQC report that identified areas. The initial focus was around the station-based drugs and management, and we had a programme of secure drug rooms being put into the stations so that we were managing the drugs in line with new regulations, which are always being updated, and we were also subject to the EU regulations. There are further changes that have happened, the Falsified Medicines Directive and also temperature monitoring, which is why this remains amber at the moment, because those are projects within the programme that have come online a little bit later. With regards to the medicines packing unit, we expect, as of last night, that we will be moving into the medicines packing unit, where all of this compliance will help us from then the rollout across the system the week beginning the 4th of October. There's been some very short delays, which is why we've rated it amber at the moment, due to being able to get equipment in and to get hardware because of supply chain issues. But everybody's been working incredibly hard to get that to there. The inventory...
So, Fenella, let's just stick with that. So we will go green?
We will go green in the next report,
Okay,
yes.
and the next bit of the question?
And then the second half of the question was about the inventory management, which is the logistics process of being able to tag all of the equipment that we have. That we saw actually being rolled out 3-4 weeks ago.
Mm-hmm.
There's a huge amount of equipment, as you'll understand, but it is on track, not off track, which is why it's amber, to indicate that it has started. The second half of that is then about how we maintain the medical devices oversight and rotate the equipment through, and that inventory management feeds into that system to provide that assurance that everything's up to date.
Thank you.
Okay, so I think actually 2 years ago, when Kadir talks about, what he's leaving behind, there was no relationship between the delivery of medicines, logistics, tracking, and this is an enormous step forward. So very well done, all of you, for doing that piece of work. It is significant and will be a much safer place to work. And I think we'll be actually at the leading edge from the tracking, from what we saw when Emily's colleague showed us when we visited. So really well done. Okay, Sheila, you looked as though you wanted to ask.
Yeah, I do. It's just a broader point, really, because we know in some of the reports that there are other challenges around delays in getting supply of construction material, etc. So I just wonder more broadly, do we need to sort of fully understand the implications of current challenges in the supply chain? And is that something we should be pulling you know, a little bit more of a structured review.
You're
of,
relating to the national problems
yes,
with supply. I
but
think
it's
a
impacting
very,
us as well in terms of some of our programmes.
That is a very good question. Do we have an instant answer to that, or should we bring that for Kadir?
No, only to say it's a fair challenge. As Sheila's pointed out, some of the delays to our move to Newham for the control room is materials for the air conditioning, etc. So perhaps at a subsequent board we can bring back an update on an overview of the supply chain challenges and the impact on the entirety of the projects and programme portfolio.
So the governance question would be, is there a risk that should be on the risk register? Is it material or not? And I think I'll ask the executive to take that away, Daniel, and look at that. But thank you for raising that, Sheila. Same point, Fenella?
Yes, I think just to provide some assurance, there are regional and national groups now looking at the supply chain of medicines and oxygen, in particular as we go into winter. And our chief pharmacist is engaged in them and is monitoring that to ensure that we don't have any shortfall. The restricted number of drugs an ambulance service administers means we are being prioritised for those drugs in a hospital as a larger formulary, so they can use different drugs to get the same effect.
Okay, thank you for that. But we'll come back. Karim.
John, can you just elaborate on why quality priority 2 is greyed out?
Yes, at Q1 we were still undertaking the baseline assessment of the number of staffing levels, so it's greyed because we hadn't made the assessment at the end of Q1. So in Q2's report, it will have a colour against it because the assessment against the KPI that we were setting hadn't been set.
And is analysis priority? Analysis is an analysis, it's not a doing thing. Is there a doing thing against the priority?
Yes, so we...
Karen, can you just make your point again? I'm sorry, I didn't quite get that.
I said, is there a doing thing against the priority because it's an analysis, not a do?
Yeah, so the recruitment plan for integrated patient care continues, and we've got an increasing headcount against the 111 workforce. This specific priority is about whether that is right to achieve the objectives in terms of responsiveness for that service line. So yes, we are continuing with our workforce recruitment plan. This is going to be assessing whether or not they have enough staff to be able to meet consistently those metrics within 111 against the change in demand that Kadir mentioned earlier.
Okay, thank you. John, you have more to tell us, I think.
The second report from me is my director report for the directorate, but also more broadly quality across the organisation. So you'll find in there an update on regulation, and we've continued to meet with the CQC. My last meeting with them and Fenella and others was on the 13th of July. Quality account priorities, we've just discussed the progress against them. In terms of quality assurance, we continue to see good reporting of incidents. We continue to see good infection prevention control, which is hugely important as we continue through this pandemic. Compliance with our call answering in the 999 service, and public engagement as one of the things we do, as well as excellence reporting continuing. Areas of note and focus are the number of open incidents, so good to see our staff continue to report incidents. Most of those, by far the majority, you'll find within the report are low or no harm, but they do need closing, and that's partly the pressures at the moment because the managers close them locally, but that will continue. And getting on top of our education and training. You obviously find yourself in an education centre today. Good to see that they are open. Just a reminder that over 1,000 students will come through these centres over this year. And our core staff will also now be going through them in the core skills refresher that you see cited in the paper. Last 2 points I'll note. One is we are going to be doing a presentation at the CQC's safeguarding event on Monday in relation to sexual safety. We've previously discussed that as a board. Yeah. And secondly, you've got the Q1 figures for the Patient Safety Incident Response Framework, which we are an early adopter for, the only ambulance service in England that's undertaking that, and you can see that actually our local plan, this board came up before my arrival, does match well to what we're finding in those incidents. Happy to take any questions.
Thank you. Questions for John. Rommel, is that? Yes.
Yes, thank you, Chair. And thank you, John, for a good report. My only question actually was on the CQC event, the fact that we've been invited to present, which is great. So does that mean we've made some real advances in sexual safety? Or are we still taking some learnings? Is there still work in progress, particularly around the East of England learnings?
So the CQC, I think I mentioned this in the previous report, did a survey across all ambulance services, both NHS and private, and this event is for everybody that they regulate in the ambulance arena. And we sent in our responses, and as part of that, they said, have you got any best practice? Of which I highlighted some areas, and then they came back to us to ask us to talk about the best practice, and hence that's what we're presenting on Monday alongside some other organisations. The areas of best practice are about how we link in with regulators when we see those, and some of the way we have got our policies in place. There's more to do, but we have got areas which have been highlighted for showcasing across the country, which is good.
And presumably you and Damien are working on that.
We've written the presentation between us.
No, I mean pick up on the actions.
Yeah, on the actions as well. Yes.
I also should say in part 2 we talk a bit more about some of the learning taken from our organisations. It's just this has gone a bit too sooner before that, but it's quite exciting. I'll talk about it in part 2.
Great.
Any other questions for John?
I have a question.
Yes, you know.
John, just and again, I think it's a great report, and thank you. It's really comprehensive and clear. You mentioned about the compliance to the safeguarding training being at 55.5%. I think that's a 3-year program, if I remember reading. So, what is are there some interventions that we need to take to improve the stats?
The intervention, unfortunately, Sheila, is time. So what we have managed to do is find, so our trainers are all able to provide the courses. The courses are on for
demand.
some of our staff. They have it built into their rate to be abstracted. For some of our service lines, that's not the case, and therefore the abstraction continues against this demand. So it will continue to improve. It's not a deficit on the education side, it's the ability to move the staff through that we're now doing. Yeah.
Okay.
We have moved as much as possible of that to online training, however, to make it easy for staff so they don't have to travel. So that is making an impact now.
And is that, are we getting sort of a positive response?
Good feedback. So they continue to be, so there's e-learning modules, but they're also doing face-to-face, and it's that bit that does get good e-learning. I think people are less keen on, but where you actually have a face-to-face session where you interact, yes, that still gets positive feedback.
So I think that gives me a good opportunity to say to my board colleagues, we have to do our mandatory training online. I can say, apart from safeguarding, which we're going to be doing at the next board meeting as a group, I am up to date. I invite my colleagues to join me to be up to date. And if you need help getting onto the ESR, because it's something one needs to do at home, really, I find when I'm on a roll, I can do it. It's finding the time, but it is important. It's part of our, when the CQC, they come, they will expect us to be up to date, and it's a leadership thing. So I would ask everybody to do it. And if new people don't know how to do it online, please talk to Diane or James, and we can get Damien's staff to facilitate it, I think. Thank you.
Good reminder.
Okay. John, is that you?
That's me.
Okay.
Yes, thank you.
Fenella, I think that moves us on to you and clinical issues.
Thank you. So I will take the report as read. I'd just like to highlight a couple of areas. So the first one, since Daniel put in his report, we have had another win at an HSJ award, which you will hear about later on in the annual public meeting. And this is a collaboration between ourselves and North Central London ICS and UCLH partners around the management of patients who are presenting with symptoms which suggest they're having a stroke. So really exciting piece of work about how we can make sure the right patients are taken to a hyperacute stroke unit. So we'll hear about that later, but they were a winner at the HSJ Awards this week. During the times of increased pressure, there is a need to maintain safety and maintain oversight, and a lot of work has been going on across all of the directorates to make sure that we have reviewed all of the processes that we had in place during COVID and bring forward the learning from COVID, the peaks of the pandemic as we prepare to go into winter, and ongoing support at a senior clinical level in both the EOC and 111 services, but also for clinicians out on the road. A lot of work is still going on across the system about how we can take patients or refer patients to the right place. And since my last report, we have opened a significant number of the same-day emergency care pathways to enable ambulance clinicians either by phone or face-to-face to refer patients in and reduce the pressure on our emergency departments, which continues to grow. And London is seeing over 100% expected numbers at the emergency departments, despite us having a 50% or below conveyance rate. So that's a piece of work that we're very engaged in around the hospital handovers. We have, despite the challenges that Kadir has already talked around, the volume of Category 2 patients, we've made significant progress in how we better manage patients who at point of contact are categorised as Category 2. So the initial information would indicate that they've got a serious condition. We know that some of those patients may well be better served with a pathway closer to home. So we have had national approval, which was led by the London Ambulance Service, to be able to further assess those patients and identify in 3 cohorts which of them need a face-to-face ambulance immediately and which would be better looked after by being able to refer into a pathway closer to home, or in some cases back to their GP in a longer period of time. That work is being reviewed by the national team, and we hope that will remain in place for winter. There's other pieces of work around how we manage the demand for those Category 2 patients from 111, which is ongoing. But what I would highlight is that our sickest patients and our most seriously ill patients, so those with an ST elevation, myocardial infarction, so a heart attack, or with stroke symptoms, are continuing to get a very fast response and get to definitive care within the national timeframes, well within the national timeframes. The last thing I would just like to highlight is that we have done a further audit on the care that we provide for our sickle cell patients. We know that in London we have the highest number of sickle cell patients in our population, and they are a really important group of patients that we look after as best we can. The audit shows that we have continued to improve, but we have now made a decision that one of the clinical performance indicators for the next year will be for sickle cell, so that we can continue to improve the care that we provide to this group of patients.
And Fenella, before, when we had a presentation to the board a couple of years ago, the issue was not giving pain relief for these people in pain.
Yes.
Can you give us some assurance on the pain relief?
So pain management has improved. The area that we are continuing to work on and to actually engage with sickle cell patients for them to share their experiences is around getting them to the right place. Many of them have a care plan that takes them to the right hospital. And the other one is around understanding that although a patient may be moving around because they're in pain, it's a way to be able to manage their pain themselves. If they are being moved out to an ambulance, we should be assisting them to be moved out, not asking them to walk out. When they go into cold air, that can make their pain get suddenly much worse. So there's a national group and a regional group, and we have set up a clinical performance indicator so that we will be able to report back on that in 6 months' time to confirm that we are continuing to improve the care.
Thank you.
Happy to take any questions.
Lovely, thank you. And I want to ask specifically Professor Karen Berry and Dr. Mark Spencer, our 2 clinicians on the board, if they would first of all like to ask anything. You've constantly rightly challenged us to focus on the clinical care, which I think we are doing more and more. So your opportunity now. Karen, do you want to go first?
Yes, thank you. So I have a question which I've been trying to formulate for a few days, so excuse me that it doesn't come out maybe properly. But obviously we've been going through a period of very high demand, and we are tasked by a set of rather arbitrary national standards to prioritise time as a performance standard.
Yeah.
And what that has meant in many areas, as far as I can see, is that the levels of clinical quality and clinical safety that or the layers that are put in to support clinical quality and clinical safety are put at risk because of operational demands. like putting clinical training managers back on the roads and things. And I would like some assurance that we're not going to do that anymore.
And who are you asking to address that?
Well, I think the exec, actually,
Yeah.
and I understand that
Okay.
there are national pressures, but I think we are in, to use an over-egged word, unprecedented times. We're certainly in unprecedented demand, which is not going to go away.
No. Okay, so it's not binary, I think, but let me ask Daniel to have a go at answering that.
Yeah.
So one of the things I was going to respond to when Fenella was talking about this thing called Category 2, which is the vast disposition that you get at the end of the triage for the 999 calls, was to say, so it's really interesting coming new to the ambulance service about how does it actually work. So when you phone 999, the call script that you're taken through is absolutely brilliant at ascertaining whether you are in a serious life-threatening emergency and we need to dispatch an ambulance really quickly. But because it's very quick set of questions, you don't get a huge amount of clinical detail about the patient. Whereas if you phone 111, the algorithm, the assessment, is much more detailed, so you end up with a much clearer understanding about what is the right resource for the patient. So what we have been starting this week to do is say if we put lots more senior clinicians to be the backup to the call handlers who are answering 999, and we start, having identified those who are really sick and dispatch an ambulance really quickly to, can we start phoning back the patients who are not really, really sick and to try and understand more? What you can get is a much more granular, these are the patients we must get to quickly, and these are the ones where it is not unsafe if they wait a bit longer. And that feels to me like a really important thing to do when you have this huge level of demand, to ensure that we get to the patients who are the most sick quickest, and we know we're doing that safely. So there's a huge amount of work that Fenella said some of, but actually there's loads more to do in that space, which I think is our board assurance for the winter. And I've been talking with my other ambulance chief exec colleagues about, does this feel like the right approach? And I think there is a consensus that we have to prioritise safety over time. So to do that, we've got to make sure we've got the patients in the right order all the time.
And the other part of your question really goes to, I think, people and culture, because you're talking about the clinical team managers who are there to support development, appraisals, get put on the road every time we're short. And so what I think we need to do is look for assurance that we have a staffing profile that allows us not to do that other than in extremis. I think it will be a never, they say never, but it should be the extreme, not the norm. And it has become a bit of the norm, I think, is your point. And we need to make sure we have a resilient workforce without taking them off those important duties.
Yeah, I mean, I think if you triangulate what John, Fenella, Kadir, and Damien a little bit have said, it's that, yes, we want to provide good quality care, but we're not really sure what the modelling for winter is. It might be good, it might be bad, it's probably going to be bad, but we need to, I think we need to realise that it's going to be very bad. If it isn't very bad, that'll be fine, and we can do other things, but it is going to be very bad.
So for members of...
Hang on a minute.
Go, sorry.
And I think Daniel's point about moving to category 2 is one part of the solution, but when we put these things in place, we need to keep the layers of safety, like CTM, like governance, there, and so they become even more important. And what I'd like for assurance really is that we're not going to get into the same place this December that we got into last December and the December before by not taking these things in triangulation.
Kadir?
I think just joining up the conversations, Karim, I think you're absolutely right. I think the response to that is what we can't do is more of the same. And I think that's where Daniel comes. The reality is that the volume of patients we see in our category 2 cohort has such a range that actually we have a huge amount of opportunities both within the London Ambulance Service, but also within the wider London health system to think about how we best meet the needs of that range of patients. And I think the danger is that we think that we need to prioritise getting an ambulance to everything. And if we do that, then we are in danger of stepping down training, reducing the management cover, supervision and support. But if we can think differently about how we do it, and I know it may sound like one initiative, but it could have quite a material and significant impact, because 70% of our calls now are Category 2 patients. Okay. And I would suggest that about 30% of that 70% require an ambulance, 40% require a different intervention. And if we can do that through our own services and through services within the wider system, we don't then have to default to asking managers to jump onto ambulances, standing down training, supervision, and therefore compromising the quality of care.
I'm going to bring Fenella in a minute, but before I do, I just wanted to clarify for the public joining us, it's not that the modelling will be bad, it's winter will be bad, and therefore we have to plan for the worst scenario. And what Jeremy are quite rightly asking to is triangulate our plan that doesn't only do the response. Daniel and others have suggested one way we're trying to do it to send less, but we have to have the right number of people without constantly taking CTMs in particular off their duties that give the assurance. So it's a bit like doing a cost improvement. You look for the clinical safety as well as the savings.
Well, yes.
So a wider plan is
what... The clinical priority trumps the operational priority. That's what I would like to see us move towards.
And so you're asking us actually to not meet national standards, which we're currently not doing across the country, not just here. Fenella, you wanted to come in.
Yeah, so I was just going to provide some assurance that we've been at REAP 4, which is obviously the highest level of escalation indicative of ongoing pressure for several weeks now. But during that time, the governance meetings have continued. The training has continued, and we've actually, with Kadir's support, rolled out the second phase of the clinical team manager training, recognising that they're the first line of clinical manager, and they need to be confident to be supporting their clinicians in their team at these times. What we have also identified is broadened out the clinicians wherever they are in the organisation, so that the pressure is not falling onto one group to provide additional resource when we need to step it up, when we see that surge in pressure, even at REAP 4, so that we can not rely on one group of clinicians the whole time.
So I think that's helpful, Fenella, but I think, Dan, it goes back to the executive needing to come up with a triangulated plan that gives that assurance, and I think it probably means more CTMs as well. And we have some group station managers that are vacant at the moment, so we need to address those issues and link to manpower.
So the last bit I would add is, one of the reasons for making John and Fenella the Deputy Chief Executives and giving them the operational portfolio as well as clinical safety and quality is so that we find it much easier to join up the triangulation between those things to give a very clear message to the organisation about what's really important. And what we're really clear about what's really important is clinical safety and quality. That is what we're here for as an ambulance trust to deliver. That has to be our number one thing. And that's what I'm pretty confident, that's what we aim to do.
And perhaps we should say that later on today we will be discussing the rest of Kadir's portfolio to ensure that we don't lose those aspects that will not come to Fenella and John, that we don't lose that joined-up approach. Yeah. I want to come to Mark Spencer as Chairman of the Quality Committee to say, is there anything you'd like to add?
Yeah, first, just to reiterate what Daniel's just said, that patient safety and care has to be the centre of what we're doing. And on the back of that, Fenella, it was really good to hear about the latest award. Will that make it quicker to roll out what you've done in North Central London across other parts of London? Because you've been telling us for a long time about how good this is, and yet we're seeing reticence across the rest of London to put in best practice. And we must work out better ways of working across the systems in London to ensure that we can do this more rapidly.
Since we won the award on Monday evening, there has been increased interest from other ICSs through to the stroke network to see how we could support it. If it is taken up by the other ICSs, and hopefully tonight when we see the presentation at the annual public meeting, it will put more information for colleagues out there, then we would be able to support it. We need to recognise that for our clinicians on scene, It adds a little bit of time on scene because they're having an interaction, but then the long journey time that we have for patients being conveyed to a specialist centre are reduced because many more of them are able to be treated more locally, which is much better for the patient and much better for their family as well. So I would say at this point, I hope we are going to see this rolled out. We know of 2 ICSs that are keen to engage.
I think your point, Mark, comes to the role of ambulance trusts who run 111 and 999 in influencing the ICSs and making sure there's a London-wide approach for these sorts of issues is paramount. And Daniel and I and others in our background will be doing more to try and encourage that. As you know, the agenda is all about elective reset, and to get elective reset, they need these systems to be working. Okay. Anything else you wanted to add, Mark, in your capacity as chair of the quality group? Nope. Okay. Thank you very much. That then moves us on to people and culture, and Damien.
Thank you very much. Thanks very much, Heather. I think I'll start just by saying I don't have a metric that measures how the impact on our staff and how hard they work. So when I go through my metrics, I almost feel that's an injustice to them. So I wanted to start off saying that it's been such a difficult few months and they've worked so hard, I can't capture that. So just to start on that point. But on more positive news, the vaccinations update is 89% first and 83% double vaccinated. And we will obviously look to improve that metric. We are rolling out flu. We've actually already started this week. We had 16 vaccinations arrive and 70 vaccinators now trained. And as of Monday the 27th, our COVID booster is open to our staff. The isolation guidance, you can see I picked up on the report, that came in mid-August, which was very much welcomed, but we didn't see the benefit of that until September. So absence is most difficult for us in July's reporting, and most of the directors have been looking at resourcing to address that. So on that notion, sickness is definitely our biggest challenge at the moment. And aside from COVID, we saw a spike in MSK and gastro. The interventions were taking place in terms of Wellbeing and trying to work out some different metrics to support that. We've also invested in the Wellbeing team. Yesterday, as an ExCo, we agreed some significant investment, which I'll update later and probably next month when that goes through the proper processes, but that's really exciting. And also we put an immediate resource into suicide prevention, just taking into account the immediate pressures. That was a preventive rather than responding to anything that actually happened in that regard. Recruitment is slightly behind plan at 68 deputy for frontline staff, but we've put in an additional 100 tech placements in Q4, so we should catch up. And turnover is still remain our KPI. It's at 9.4%, which is really good. I just want to end on 3 very positive pieces of work we'll be doing this month. ESR self-service for managers rolled out, even during operational pressures. That gives our staff more control, gives our managers more empowerment to take control of it rather than going through the central, which is great. Secondly, you have seen the report, our staff survey planning, and I can report as of this week, we are leading the ambulance sector for compliance at 10.1%. That's nationally, which is great. And finally, last time I was here, I updated you that 41% of our new starters from the BAME community, which was fantastic. But this month, I can update you, is 58% in July. So we're starting to see some real progress in that metric as well. I'll take it as read. Any questions?
Thank you. Questions for Damien? Rommel.
Damien, I just pick up on one of the challenges which comes through from the number of the reports. Absence seems to be an issue that is really concerning. I mean, what is it we can do to bring that back under control?
Yeah, so we've boosted the HR team to look at the retrospect of taking people through the policy, etc., to make sure that's in line. But actually, we're trying to approach from a different perspective now. We've set up a work stream which has been led by paramedics, not by HR team, to look at the culture of absence reporting, etc. I think it is a reflection of the pressure on the system, in all honesty. And we've got to look at much better wellbeing interventions. And as I was saying yesterday, we've boosted our wellbeing team significantly. We'll update on that, but we need. It's a combination of everything coming together, high overtime, the pressure in the system, and as a result, I think we're picking a burnout quite a bit. I would say, and it's in my report, this is reflected nationally. We benchmark with the ambulance sectors. It's not a place we want to be. I'm not saying we should be at this place and we're putting intervention budget, but we are benchmarking with the system.
Can I ask a question about the staff survey? I'm less interested in the percentages of people replying in the work we're doing to prepare staff for the good things that have happened as well as the issues. Because in my experience, that's a piece of work that needs to be done consistently, persistently. It's not that you're trying to tell people what to put in the boxes. It's that we've moved so fast, it's been so pressurised, it's difficult for frontline staff, or all staff, to remember the good things. And have we got a programme that is also doing that to help remind people of the balance of the experience?
Yeah, so is that kind of we said, you said we did. So for this year, we've taken a slightly different approach. We're going to do it jointly with partnership with the unions. So now they chair the forum and the messages and how we send our what we did well out there. I think, in all honesty, with such a difficult time over the past year, this year's survey is going to be really critical to make the culture change. It'll combine with the culture transformation programme, which I'll update the next board. They all come together, and that information as well as that work will be the real metrics, I think, for the we said you did.
Do you think you could share about the recruitment team and what somebody in your team's been working on with them and the difference in their survey response, the local survey response?
Yeah, sure. So for the recruitment team, I think we had a high level of turnover, if I'm honest. I think our processes are too long, and I think it's not supporting our managers and their precious time that they have. So it was right at the time with governance, and I think with the new technology we can make that process more streamlined. But rather than, again, it's my ethos at the moment, rather than it being led by the HR team, we're putting staff that used to be paramedics. So my business manager used to be a paramedic. She runs that program with the QI team, and they're approaching it from a QI methodology about making change. So rather than us going and say the process is X, Y, Z and streamline it, we're actually saying, well, what does the front line actually need? How do they work it? It's taken probably 2 to 3 months, but it's good investment because it's obviously a long-term change. And we're starting to see the HR team be more engaged with the service and feel their owning and the connection with the audience, the customers, is there. That methodology we're going to try and take into the sickness absence group is just to try things a little bit differently with a QI lens.
And you're using the plan, do, act, review, which is people understand, everybody gets it. And I saw some enthusiasm when I was talking to staff. So if we can do more of that consistently across the organisation, that will also help the culture change. So well done. Thank you. Anything else, or can we move on? Should we move on then? Thank you for that. That takes us to finance and audit. So starting with your report, Lorraine, please.
Yes, thank you. Good morning, everybody. So the report that I have, I'll take as read. It covers the period to July, the first 4 months, that's set out in the Integrated Performance Report. Just as a reminder, I'll just draw out a few things. As a reminder that we have been working under an adjusted financial framework, block allocations, and continue to do so for the first half of the year. And that plan was based on a winter run rate in terms of the block allocation and some top-ups. Up until month 3, we were broadly on plan, but the position for month 4, and this has continued into month 5, has deteriorated as a result of the very significant uptick in the demand. So as at month 4, we are reporting a 1.2 million deficit. However, we were notified, I think we reported at the last board, that there's special monies that have been identified nationally, 55 million in total. So when we're looking at the first half of the year, we are still expecting to break even because we will be factoring that in. In terms of the second half of the year, I think as at the time of publishing this report, we hadn't received the detailed guidance. We have now received the high-level allocation. So there is a settlement nationally of 5.4 billion, and those allocations are now being worked through to the system level. We are right now in the middle of identifying how those get allocated to provider organisations, and so as a result we've got a bit more detailed work to do, and we'll be considering this in some detail in the private part of the session. The only other thing I just want to flag, and then I'll take questions on the detail, is that we've been reporting the need to continue the capital spend and the programmes that we commenced on the back of the COVID spend, where we significantly made significant inroads into some of our legacy infrastructure. The good news and positive news is that the headlines in terms of the settlement will include some capital budget and cash, because I know that has been a sort of concern that we do need to continue to spend more than the 26 million that we've currently got confirmed. So I think that will be positive. And I think just the final thing, we know that to some extent the first half of the year, sort of the focus has been, well, money is not a constraint. It is very clear that the second half of the year will be much tighter, and clearly we're starting to commence those conversations with our commissioners now to ensure that we get a settlement that reflects the increased demand that we are projecting to continue. So I'm very happy to take questions on the detail.
Thank you, Lorraine. Jill, you've got your hand up quickly.
Yeah, thanks very much, Lorraine. I just wonder if you could just help me understand a little bit more what you're saying, and then a follow-up question to that. So if I understand it correctly, year to date, there's a deficit of 1.2 million, but that assumes we get a 4.6 million pound payment from North West London. So the underlying deficit is actually 5.8 million. So it's a run rate of about £1.5 to £2 million a year. So I'm just wondering how confident we are that we're going to be able to come back onto plan by the half year and the end of the year. Sort of, if I could just one further point, I'm just wondering, which links to the scenario question we were talking about earlier on. I wonder whether or not we should actually just work through a couple of financial scenarios, what the outturn of the year might look like, given the demand cone that we just talked about earlier in the meeting.
Jill, could I suggest that we pick this up in part B, because Lorraine has to explain to us about H2 and what that allocation is looking like and what the implications would be, and we'll look at it in more detail. I think it's difficult to do it now because of, there's uncertainty, but there are points we can pick up. So the scenario planning, as you say, and the ability to return to a balanced position, but it's all a bit contingent at the moment. Lorraine, are you content with doing it that way in part B?
Very, very happy to, yes.
It gives us more time, because it is complicated and it's not certain. Yeah?
Okay.
Daniel, are you happy with that?
Okay, thanks.
Yeah. Thank you. Other questions for Lorraine? Okay. Thank you, Lorraine. So then we go to assurance. We have had a Finance and Investment Committee chaired by Bob for his first meeting, having taken over from Amit, who, thank you, Amit, for doing it in the interim, really helpful. Bob.
Thank you, Chair. And it was the end of last week, so there isn't a written report. So,
yeah, sure.
Apologies for that. I mean, we considered a number of matters contractual that are going to either be part of further private discussion or will be coming back to the board in the future. So I don't think there's a great deal to be done with airing those now. We spoke about the month 4 position, the emerging month 5 position, and the CFO's view of what that meant for the half year, so aligned with the question that Jill asked before, and we'll pick that up in private. And we had some discussion about the implications of our knowledge at that time of what the second half year settlement would be, and the implications that would have for H2 planning. And again, we'll discuss that in slide time in in this afternoon in a later session. I suppose two particular things that Lorraine hasn't spoken about, but the committee got some assurance of, were the update on where we are with the transformation of procurement function, and that was very positive, but we've asked for some more granular targeting of action, and also where the finance function has got to on its own improvement programme. And again, that was very positive, but again, we've asked for some more granular things to come back to us, because that sort of thing never really ends. I think all in all, it was a good discussion, and we'll follow that through later. And there were some key assurance points that we took in terms of work that's obviously been ongoing for some time before my starting.
Thank you. So for members of the public who think it's bizarre that we don't know what our second half of the year allocation is, it is bizarre, and it is because of the pandemic. It's the first time in my career this has happened, and probably Bob's, I would think Lorraine's as well. So we will be doing in the public meeting next month what the financials look like for the second half of the year. But we are in the second half of the year, and we don't actually know. That is across the whole of the NHS, not just LAS. Thank you. So we do have an assurance report from the Audit Committee that Rommel chairs. Rommel.
Thank you, Chair. So it's a bit of a heavy report, so it picks up July and September. Just to pick out a couple of points that I wanted to talk to inform the board about. I think the Audit Committee is very pleased to see, firstly, a fresh pair of eyes with the new CEO coming in. And in that context, there is going to be a refresh of the BAF and the corporate risks. And also pleased to see that those are being aligned, actually, from a governance point of view under the Director of Corporate Affairs, because there's been a bit of a disconnect previously. In that context, I think following that work, we welcome the new internal auditors and saw the outgoing internal auditors. So Grant Thornton left us with some significant assurance reports on workforce planning and IPC and our CIP benefit realisation. However, pointing to the earlier discussion we had about equality and diversity, there is a partial assurance report, so, and a few actions I think still to address there. In terms of the new internal auditors who are BDO, they will be reassessing the internal audit plan in the context of what Daniel and the team are looking at in refreshing and resetting the BAF and the corporate risk registers. And following that review, they will undertake a risk maturity audit. But their initial focus is going to be on some of the basic controls. They will be writing to me and the Audit Committee, and actually Daniel, which I've asked them to do, to talk to what does that reset plan look like. We also welcome the new counter-fraud auditors who start on the 1st of October, RSM. And again, I've been having separate bilaterals with each of them. So I think in terms of Audit Committee assurance, there's still work to be done. We're looking at strengthening. We want to see strengthened first line, second line, and third line. The third line I've talked about in terms of the RSM and BDO. Second line, I think in terms of Diane's role going forward and the team, pulling that together and having that lens on risk management is going to be quite important. And I think the Audit Committee is going to welcome perspectives and views from that function going forward. And in terms of the first line, picking up an action from the year end, just for board to note, the CFO is going to be accountable for the annual report and accounts process, which is good and welcome. And in that context, there will be a process where we're going to be asking for directors' assurance statements, which will inform the preparation and production of the annual governance statement. So that's the kind of perspective that we've got. There's still work in train on first, second, and third lines of defence. The other notable point I just wanted the board to be aware of is we took a report on EPRR, which was interesting to pick up, and this was a self-assessment gap analysis. And there's a few actions they are going to come back to Audit Committee before they come to board. I think it is in early January, Kadir, with the annual assurance. What came out of that, I think, is, which I wanted to highlight to board, is I think there is a need to have a strategic discussion in the round and in the context of other plans that we have to transform the London Ambulance Service, because I think there are significant resource implications of some of those gap assessments. And the other point that came out of that discussion was the need to continually retest and ensure that our disaster recovery business continuity arrangements are not something separate, but are actually integral to how we operate in terms of urgent and emergency care. So those are the points I'd like to draw, but if there's any questions, I'm happy to take them.
Thank you. Sheila,
I just had one point, just to underline that point, because it was a very good discussion we had at the Audit Committee on the disaster recovery and business continuity, and particularly in the context of the transformational changes that we're making. And often I think, you know, one lays in new systems and new changes and perhaps doesn't look as carefully at, you know, is there now a change in working practice or a change in how we deliver services that needs to be reviewed from a business continuity and disaster recovery perspective. So I think it was a very good discussion, and I think it'll be important that we keep an eye on that as we lay in a number of the changes that we're making across the Trust.
So for the many things that our new Chief Exec has to do, that probably is on his objective list, I rather feel, and we can pick that up. Thank you. I think also, Rommel, having had the discussion in another environment where some of us were about the first, second, third line of defence, maybe in either the October board meeting or this afternoon, we should make sure that everybody understands what each of those is. Might be just a revision class.
That's
for
helpful,
people.
Helen. That's a really good reminder, because part of the work Audit Committee has asked for, which has been on the list of to-dos, is an assurance map, which actually is the clarity of what you've just asked for.
Okay.
First, second and third line.
So if we can pick that up. Thank you very much. Anything else for Rommel? No, these are important meetings, these subcommittees. Thank you very much.
Do you think we should just, for people watching, say what EPR are?
Yes, that was the other thing. Do you go on then?
So basically, it's emergency planning and resilience. And on that subject, yesterday we did a full-scale test of our what would happen if there was an awful incident in London, and would we be prepared?
Yes.
And it was very reassuring that we would be able to respond well.
Yes.
So.
I mean, I would like to pick up maybe later on the gaps, because certainly when I have personally been through all the actions arising out of all the previous events and checked with Kadir and Daniel, we have actioned all of those, and it's reassuring now to know, or assuring really, that you've had a practice run, so we need to be clear what those are. But in terms of staffing for heart, for example, and training in particular, and the hot, warm zones of where a paramedic can go and can't go in those incidents was much clearer.
Yes.
And the fact that only the police can declare a Plato, thank you. You all know what I was about to say. Plato incident is crucial. So
yes, so that was a big part of the test yesterday.
Good.
Was about warm and cold and hot, and it went fine.
Great. So this is again for members of the public. At London Bridge in particular, there was concern by the public about whether our staff that were there didn't seem to go in. And at the time, the rules were that certain people couldn't go in because of the designation of hot, medium and cold. And that has changed. But we do need to make sure our staff wear their stab vests, and ideally, when we've got them, the security cameras.
Yes,
Okay.
so we tried that too.
Good.
And I was equipped
Well
to
done.
take it out as a go to find out what it's actually like to wear all of the protection. And I
It
can
would
tell
be
you
good
it's...
to do a session when we've a little more time on that whole EPPR, so maybe a board development day. If newer members of the board, not the newest, but before that, we went to Clock House to when Kadir was new, to see all the equipment and to meet our staff and hear about it. And it's probably timely to do all that again with changes on the board. Okay. Karim?
Just to note, I think that EPPR extends beyond the acute event into more temporarily distributed events, like being in REAP 4 for several weeks.
Mm-hmm. True.
And potentially, well, we are in the middle of a disaster scenario at the moment, despite not being declared as one in the same way that we were last week. And that has, so we are in an active business continuity and resilience situation at the moment. And we may also be asked to respond to a terrorist event in the middle of another thing. So there are two
added challenges
there,
Yes, and as I think was reported before, our staff were at Heathrow when the Afghani people were evacuated to us. So they do have a wide role, and we need to make sure they feel part of the organisation as well. And I did hear, as you probably know, people will know in the organisation, it's a very male-dominated part of the organisation. And I happened to be sitting next to Mark Rainey at where we were remembering those who died in the ambulance services across the country, and he was telling me how he's got a recruitment drive to have many more women in it.
Well,
so if we can then get diversity, it's really great.
Yes, the two people who led it yesterday were both female.
Well, there you go. That's good. But they have, at the moment, it's a predominantly male, Caucasian service, which we need to change to being gender neutral in terms of, 50% of each, if possible, and ethnic minority.
Yes.
But that certainly the gender one was being addressed. I was pleased to hear that, because it has been an issue.
And just pick up on Karim's point, we did factor in that in the scenario that we were already very busy.
Yes.
How would we respond in that context? So,
well, maybe a presentation onto the board later would be great. But it's good to hear that you've done it. Thank you. And if you then had, cybersecurity can be part of that attack. So systems down. I was glad to see we put new generators in this week, but it's part of the cybersecurity as well as the physical, possible bomb or whatever. So we'll look at it in the round. Thank you. Well reminded. Okay, that moves us on then, I think, to logistics and infrastructure report. And is that's the assurance report coming from Sheila?
Yeah, thank you, Chair. So I'll take the report as read. I just wanted to call out 3 points for the board. The first one, we've already referenced this earlier, but we noted the delay to the move of the Emergency Operations Centre from Bow to Newham, and that's largely down to delays in the supply chain for construction-related materials. But we did talk about, let's take this opportunity to look at now, the impact of that might have on other dependencies we have, other projects. And it's one thing I know that colleagues are really keen to see that sort of link of all these projects so we can understand, the sequencing and the critical dependencies. And we were pleased to hear that there's work that's now taking place that will surface that, and that will be a great piece of assurance for us, I think, in the future when we see that integrated report that shows us the links between all the different projects and the sequencing of those projects, so that we can be confident that the decisions we're making are very sound decisions, and we're not rushing to do something in isolation of understanding the connectivity with other work that's ongoing. So we'll be pleased to see that coming back to LIC in due course.
And who's doing that, Sheila?
It was Mark
Edgerton, Projects and Programme colleagues.
Yeah. But I think it's something that Daniel has also mentioned is very important, and we're really pleased to hear Daniel say that. The other thing just to call out is we received a briefing paper on work that's ongoing, and I mentioned this in my last assurance report, looking at what is the optimum path to achieving our ultra-low emissions and our zero emissions ambition. I mean, it's a very complicated set of options at the moment. It's quite a significant investment, so the exec is taking that away to look at, how will we actually achieve the targets that have been set, what are the options we can take, and what are the decisions we need to take in the future. One of the things we did ask was that we haven't seen an updated fleet strategy for quite some time, and we think it would be really helpful to anchor this work to a more holistic strategy around fleet, how our fleet aligns to the operating model, to our ambition around zero emissions, and of course to the long-term plans we have around how we want to manage and maintain our fleet into the future. So I think there's going to be some work on that, Daniel, but I'm not sure if we're going to get it. I know we said we would convene an extra meeting in October if need be, just to start discussing that, but I don't know if you want to comment.
So I think both the fleet strategy and the estate strategy actually require a huge amount of work. So we can do iterative bits for the moment, but actually we need a whole big refresh of both of them, and it needs to then form part of the whole clinical strategy refresh for the organisation that we alluded to earlier about how do we actually think care is going to be delivered in the next 5 to 10 years to make sure we have the right fleet with the right buildings. It's quite big. But there's some short-term stuff that we have to do to be ULEZ, which is the low emission zone compliant for London in that context.
And an estate strategy would be very warmly welcomed.
Yes, it would. I mean, it's on our list of
been asking.
activities we've been asking for, but again, perhaps we could just, and maybe we can take this offline just in terms of timing for when we might see some of those strategies coming forward. Appreciate there's a lot of work to do.
But I think they will be rate limiting factors to our capital spend at a time when capital is going to get increasingly difficult. So we need to think about how we do that.
Yeah.
Okay, thank you.
And then, sorry, one final point I just wanted to raise. We discussed the BAFRIS, so BAFRIS 45, which is our, risk of a cyber failure, and 58, the risk of, a catastrophic IT failure, so basically our IT resilience. And we discussed those, especially in the context of the work that Barry Thurston, our CIO, and his team are doing to improve and make investments in improving both our telecommunications but also our telephony infrastructure, which we know needs a lot of work, and also the computer-aided dispatch, the new computer-aided dispatch system, and the work they're doing to improve our cyber controls. So there's a huge amount of work ongoing within that team. And I just wanted to call out, because we were really pleased to hear Daniel underline the importance of focus and investment in these areas to improve resilience of key infrastructure and to make sure we're focusing, our scarce resources in driving those changes forward. So I just wanted to say we're really pleased to hear that, Daniel, and thank you.
Good, thank you. Any questions for Sheila? Rommel?
Another question, just to reinforce something Sheila said. I think the context in which the organisation is facing its current pressures, which Karim highlighted earlier, REAP for sustained periods, but also a lot of transformation in progress, is people are at the heart of this. And I think, not to add to Damien's already long list, but I think the need for an integrated people plan that looks across the kind of pressures on our people for business as usual, but also transformation and change. So this context of change management and how we're approaching it.
Damien?
Thanks, Rommel. Myself and Anne are meeting in October with Daniel to do exactly that, to rewrite the plan.
Good. I have to say, I have a feeling of the hamster on the wheel with so much to do, and I keep putting things Damien's way that are urgent for now, whilst also trying to deal with the long term. And I think that's really what we're all dealing with in this REAP 4, whether you're frontline people or support. There is so much to be done. So we're going to have to say top few priorities, what goes first, what comes second. And there's a danger to think it all comes first, and it can't. So we have to balance that out, which we can do. And I'll be working with Daniel in the background to see if we can get a bit of sense on that. Thank you. Okay. So working with the public and patients is really important. And this is the next item of getting feedback from Anthony, our Director of Communications and Public Engagement, on where we've got to with the Patient and Public Council. I'm not sure we have Dame Christine today, our chairman of that group.
Unfortunately not, Heather. She's given apologies. She couldn't join. For people who don't know, Dame Chris is the co-chair of the council, along with Michael Bryan. Just a reminder for people who don't know, the council was set up, so the Public Patient Council was set up to provide a voice for patients, the public and carers in the design, development and delivery of our services. In this pack is the notes of the May meeting of the council, which it meets quarterly, and as well as having its regular meeting, has subgroups. The main meeting focused on a range of areas, including giving members an opportunity to feed into our response to a number of national consultations. A number of the members also gave feedback at the meeting about their involvement in the station accreditation programs. That's the Station Quality Accreditation Program, which went down very well with them, and they felt very involved and able to shape the work that was underway. And a number of members also gave feedback about their involvement in the Ambulance Design Day which was shaping how patients, or shaping for them to give feedback about the future design of ambulances and obviously how they could be better for patients. Also in the pack is the agenda of the council's August meeting, so we bring the notes after they've, or the minutes after they've been approved. This meeting focused on the services of our mental health team and end-of-life care team, and the two teams gave feedback about the way they have already involved patients and the public, but also ideas for how they can involve them further as we move forward. And again, really positive feedback, and both Diane Lafferty and Kylie Lynch were really pleased with what they got and how they can take that forward. As I said, there's a number of subgroups. There's 10 subgroups that also run in addition to the regular meetings. And one of these is the EPCR, so the Electronic Patient Care Record Group. And they've been recently helping the team to shape our approach to capturing clinical images so that they can be uploaded to the Electronic Patient Care Record. And they've helped the team explore what considerations need to be taken into account from a patient perspective, so that they can then be, one, have the image taken, but then uploaded to make sure that we meet all of the necessary obligations and legal requirements. Again, very positive, and the team have written to me, so the EPCR team have written to me to say how helpful it was and how important it was to them. The next meeting of the council is in November, so obviously provide the feedback from that meeting then. So obviously ask the board to note this report.
Thank you very much, Anthony. Any questions? Bob?
Thank you, Chair. I'd see in the minutes of the session you had in August that you had observers from the emerging ICSs in London, and I just wonder what thought's been given to dovetail this piece into the inevitability of 5 patient and public engagement processes going on in the ICSs. This is either going to be marvellous because it means it can feed into it, and I mean, the last thing you want is duplication, or groups of people happily having the same conversation and coming up with different helpful comments. And I just wonder what thought had got into that so far.
Quite a lot, actually. So we have having exactly that same conversation, that there's a real risk of, obviously there's things very specific to the London Ambulance Service that will need that, but those wider pictures. So we're talking to all of the ICS engagement leads about how we can do that, and also talking to Local Health Watch about how we can minimise the need. We have 32 Health Watch in London, how we can minimise the need to have to talk to, although we want to talk to, 32 different Health Watch, so how we can do that too. So it's still early days to an extent, but there are actually weekly meetings with the 5 ICSs to talk about that and explore it as we move forward.
Thank you.
And I think building on that, Bob, it's the whole bit about public health messages, which working with the ICSs we could do with the public, because we need to shift public behaviour. There's still the view, if you dial 999, you get an ambulance. And as we know, we don't take 50% of those people, but there's another cohort that we needn't take. But a lot of the concerns that are raised from the public that come as complaints are, I didn't get an ambulance. And so we need to address that issue, let alone the others that could help people help themselves in the broader context.
We did actually talk, and John might want to talk to what he said at the meeting. So at the August meeting, we talked about non-compliance. It's actually one of the agenda items, and John gave a very helpful presentation, and they gave feedback on that. I don't know if, John, you wanted to add anything?
Yeah, Heather was there,
It was
actually.
brilliant.
So,
it was brilliant,
we
John.
outlined using some patient examples that when an ambulance is called, we don't necessarily send an ambulance. So our hear and treat rate means that we don't send an ambulance at all, but we provide advice over the telephone, refer patients to other settings where appropriate. And when we do arrive, we don't always take patients to hospital, and explained why that might be the case.
But for me, it was going back to Bob's point, we can do that times 5. You know, it's how do we... It's taking further this. We need the integrated care systems to say they come to us for that, and they can then disseminate out rather than us having to go to 5. And that is, you know, it's why my personal view is we do need a London Regional Board for urgent and emergency care services. It is the view of the ambulance sector, all but the one that only has 1 ICS. So I shall keep making that point. Karim?
Just a comment and then a question. Just specifically to that, I think I don't agree. The role of the Patient and Public Forum for LAS is to inform and shape LAS's services. It's not to provide support for the entire ICS system, and there, you know, and Anthony's curated a specific patient group and public group to enable that. And you know, I don't think they're there to answer the whole questions of London-wide NHS. They're there to shape our services, obviously in the context of the system. So I think it's important that the forum stays within LAS and as shaped. I think
No, I agree with that. I wasn't suggesting it shouldn't.
that was what I picked up from
No, but they need to link into us for that and feedback the other way, rather than us having to go and regurgitate our story 5 times.
Yeah, and that's about communications out from us.
Yeah.
What I was going to say is, I think the forum, although I've not made a meeting, I'm sorry, as a step change, you know, from where we were 2 years ago, and is a real success story. And I think the way that they're shaping services now is important. I think it'd be really important for them to take a view on potential changes around things like CAT 2 and clinical priorities and things, because I think that could be potentially very supportive.
That's helpful, Karen, thank you.
On the ICS question, I think the other part of the remit of the council, as well as advising our services, is how we engage more widely across London. So that bit of, they've already spoken about the ICS conversation, and obviously saying to us, we're saying, taking their advice, but actually how can we do it more widely? And their point they've made, as well as, you know, we recognise that we can't have this conversation 5 times if we go outside. So how can we work with the ICSs? So that is part of their role to advise us on how to engage more broadly.
But it's a spider's web, isn't it? So, okay, that's helpful. Thank you, Anthony. And thank you back to Chris and the team for what they're doing, because we really do appreciate it. As Karen said, it's a sea change from where we were. That's really good. Thank you. Okay, just before we move on to Assurance Committee aspects, can I just go back, Daniel? I know we will be talking about South West London 111 in Part B, but we didn't pick it up on Kadir's report. So could we just talk about the importance of 111, why we do it, and what we've been asked to do, please?
We can, Chair. My apologies. So just to give an update to colleagues, I'm pleased to report that South West London ICS colleagues have asked the London Ambulance Service to support in some of the operational resilience of the integrated urgent care services in South West London. So integrated urgent care provides, is essentially known as the 111 service. It provides an alternative to 999 where the need is not an emergency but considered an urgent need. Comes through to a call handler, has a pathways assessment, a nationally recognised NHS triage tool, and then determines the best course of action. That could either be a booking into a GP, access of community services, or a clinical callback from a clinician within the 111 service. In South West London, given some of the demand that they've currently been experiencing and some of the challenges around some of the operational performance, we were asked to support. The London Ambulance Service was asked to support South West London colleagues in meeting and managing some of that demand. So we've been able to step into South West London and provide some of the services that we already provide in North East London, South East London, and North West London. And what we've been asked to provide specifically is a level of service provision that I would suggest is best provided by the London Ambulance Service, because it speaks to some of the areas of work that we that sits within our remit responsibility and reflects our areas of particular focus. So we've been asked to provide 14% of South West London's 111 call answering service, 7 days a week, and in the coming months to further support that by being able to triage some of their category and 3 and 4 ambulance dispositions. So those calls that come to South West London 111 service that the triage tool suggests requires an ambulance will then be reviewed by London Ambulance Service clinicians in order to ensure that an ambulance is in fact required and an alternative care pathway can't be provided. We'll also be asked to facilitate and provide the Star 5 call answering facility. That's where one of our crews on scene is with a patient and believes that a conveyance is not in the best interest of that patient, but an alternative care pathway may be. And so they can call 111 Star 5, and that provides a specific service that the London Ambulance Service can provide that patient and that clinician, that LAS clinician on scene. So we launched that service this month and are currently delivering very, very high levels of operational performance.
Thank you, Kadir. Questions for Kadir on that? Karen.
Are we going to be paid properly for the service?
We absolutely are. So a really, really healthy and productive conversation with our South West London ICS colleagues in order to make sure what we used to call full cost recovery. I don't know whether that term is used anymore, but a very, very clear and detailed costed provision that reflects both the needs of the service, but also some of the overheads to provide that for the London Ambulance Service. So very much with a rigorous financial assessment around the value of each individual call.
It's a very helpful question because whilst it's totally consistent with the strategy for us to be the integrated version of emergency care, there are some assurance issues that we need to pick up, which we can do outside of this meeting, as you know, with the history of 111 across the trust. So thank you. Daniel.
So just two things. So this just came into my in-tray just as I arrived. So I am assured that we have the manpower to do the South West London work without undermining
the people power.
The people power, sorry. To do the work without compromising our services in North East London and South East London, and so far that is true. And the second bit is, I think 111 providers having resilience partners is really sensible. Mm-hmm. So the call volume fluctuates so widely between different parts of the day and also in different parts of the country that actually having a network system where people help out each other is really sensible. It's how the 999 service works, and increasingly is how 111 works. So we have partners in Derbyshire, Hertfordshire, as well as within London, and it's a very successful way of working.
If we could just add, because Daniel's already said it, so it's the London Ambulance Service that pioneers that approach. So our partnerships with Derbyshire, Health United, Hertfordshire Urgent Care are kind of firsts in terms of delivering not just regional resilience, but a national resilience from an ambulance service.
Thank you. I just thought it was important that we covered that off. So moving on to board assurance then, I'm really pleased to see this. Diane, do you want to take us through?
Yes, thank you, Chair, and good morning. So agenda item 10, Board Assurance Committee Terms of Reference. Paper shows the revised changes to the Terms of Reference and other appointed committees. These are shown in detail in terms of reference themselves in red font in Appendix 1, but in summary, the minor changes are the updated job titles, the quorum to the Logistics and Infrastructure Committee at 8.1, and then also there were a couple of other minor amendments that weren't included in the paper, and that was around the Logistics and Infrastructure Committee 12.2 to remove data protection. This was previously agreed to transfer to the Quality Assurance Committee. And then there was reference to a Deputy Director of Finance that should read Financial Controller. So during the terms of reference discussions at the committees, it was the following were reported to board for information and consideration. So discussion around committee chairs able to provide verbal updates to the board rather than written, just for a discussion, Chair. Where appropriate, consideration for the public board to follow the private board if necessary, so to turn the meetings around in occasions it may help. Mm-hmm. And then the Logistics and Infrastructure Committee advised that its membership would benefit from clinical input at director level, and noting the imminent director level changes, this would be proposed to go on to the membership.
Thank
It's also noted that the People and Culture Committee and Quality Assurance Committee did not meet during the time of the term of reference review. However, all members were sent the terms of reference electronically to comment. So membership changes to the board. Bob Alexander and Dr. Anne Rainsbury have joined as non-executive directors, and Linda Decker as an associate non-executive director. An updated list of memberships of the board assurance committees is also attached at Appendix 2. That's behind the Quality Assurance Committee terms of reference. And it includes charitable funds and the small limited companies information as well. So for information as well, a review of the trust governance structure and assurance is about to take place over the next 6 weeks, which may also result in proposed amendments further to the board. So I'm happy to take questions, and there's a recommendation as well.
Thank you very much, Diane. That's really helpful. So the one I think I would like to start with, which I think is easy personally, is to do the private part before the public part of the meeting. Does anybody want to disagree with that element? No? Are we content to do that? The one I've got a view on, so I will ask my subcommittee chairs their view about a written report or a verbal report from the assurance chairs. Rommel, let's kick off with you.
I guess I'm the one who raised the point.
Oh, right, did you? Right, moving swiftly on.
well, possibly because on my other boards and other audit committees, it is kind of common practice to provide a verbal assurance. All the minutes are made available for board members anyway. I guess I'm doing it from a selfish perspective and saying, you know, I think all of us are giving a good verbal account of what is taking place. Is it adding anything to actually have a written report? So that's where I was coming from.
Okay, so that's your view. Mark, do you want to comment from quality perspective and generally on it?
I think, whilst agreeing as always with Rommel, I think for people dialing in who won't, you know, in this board meeting, we hope we have public listening in who won't have had the opportunities to read all the papers. A brief summary that's a written record providing assurance of the work we're doing, I think could be helpful.
Yeah, okay, thank you.
I agree with Rommel, it's a bit of a pain to do. But I think for transparency and enabling people to see what we're doing, it could be helpful.
Okay, Sheila?
I'm very supportive because I think also...
Of having a report?
No, of having a verbal update, because I think also it puts pressure on the Secretariat to try and produce the minutes really quickly so that we can, when we're writing our assurance reports, we can make sure we haven't missed anything
Except
really
for we
critical.
do want the minutes very quickly.
Yeah, but I think, you know, I find I finish the meeting, I need to write the report pretty much straight after, because otherwise I'm waiting for minutes that could take some time. So it does take a bit of pressure off, I think.
Bob, do you have a view?
So in other places I do both. I think if we're going to continue with a written report from the committee chair, I think it's beholden on two things. I mean, I agree with Sheila completely about the importance of getting the minutes out quick. But frankly, you need the minutes out quick, full stop, regardless of whether we do it. If we're going to keep with a written report, then I think we need to have the discipline of it being quite short, succinct, and utterly consistent. And the only thing you would really want to make sure you do is not to basically rewrite the minutes in the way I write, as opposed to the way the Secretariat writes, is key issues of escalation.
Yes.
So that, but I mean, that could be done in a paragraph. But I'm pretty agnostic, Chair, to be honest with you. I mean, I recognise completely the views that colleagues have had. I do both, and you do both if you have to.
I mean, you were chairing a committee for a while. What's your view?
I actually personally find that having to be explicit about the items for escalation at least, and having those noted down and being able to scan across the various committees in the run-up to this and see what was considered most important is valuable. Maybe they could be shorter. They don't necessarily need to be a sort of as fulsome. But I personally, you know, there are committees I don't attend, and knowing what was most important at a glance from the matters for escalation, for instance, is useful, because I think gleaning that from minutes is not always obvious.
So, having listened to a range of views, I'm going to share mine, which is I think it is important and good governance to have these reports, but they need to be succinct and have the matters for escalation. So for now, I would like to keep them. Whether it comes out of our review of governance, and we might have that wider debate and see what the Good Governance Institute say, I'm prepared to look at that in the round, but I do think it's good governance. We need to make it easy for you to do it, which does mean, and Diane's aware of this, making sure she's got a team available to do those minutes in a very timely way, and that we don't put undue pressure on you. But like Mark, I think if you're a member of the public, you couldn't quickly get it. And as Amit says, you can scan across and be on. And I think it probably helps the executive keep focused, actually. You get lots of minutes, there are lots of meetings. So for now, I apologise, but we're keeping it. Thank you. Chairman's action. Diane.
Thank you, Chair. So I think from me, I take away trying to make a pro forma that will assist around the short, succinct, consistent key issues of escalation. I know we've got meetings set with chairs and lead executives very soon to make sure that each committee is running the way that people would like. So they're in the diary.
Thank you.
Thanks. So the recommendation then, Chair, is...
We note the changes to the names and the membership. We note that we're going to have a governance review and some of that may change. We've talked before about the FIC and LIC coming together, for example, and that may come out of that. And for now, I would like us as Chair to keep those assurance reports, but in a way that facilitates the non-execs to do it.
Thank you.
Thank you. So that takes us on to, I'm very pleased to see procedural documents, policy and corporate policies on this agenda.
Yep. So I can put this down to James and his good work
Well done,
before
James.
I actually joined the organisation, and he's very au fait with our procedural documents policy. So there are 3 trust policies for the board to review today and approve. And the one that is the key one is the TP001, the policy for the development and implementation of procedural documents. Very snappy title, but I call it a policy for policies. So as part of the review and the update, the opportunity was taken to review that policy for policies and to add clarity to the approval process. We did find that we kind of slipped behind on policies, trust policies, which has now become a risk, which will be identified later on. But we've identified the list of policies with clear approval and review route.
Much better.
We've clarified the list of core policies, which are the responsibility of the Trust Board, and the organisational policies, which are agreed by the Exec Committee or Director level. Clarity on policy review intervals, which is key. And a reduction of the overall number of policies by grouping. And recently, Damien had condensed, I think, 6 or 7 documents into one policy, which was very,
So if everybody could follow that lead, Damien, because I've never known a place with only policies, and most of them are procedures, which is probably what you found.
Yeah.
So that's the first key one for us to review and agree. TP003, which is a fit and proper persons policy, and TP004, the policy on managing conflicts of interest. There's no major updates are proposed, and all changes are shown in red font, Chair. These policies have been reviewed and supported by the Executive Committee, EXCO.
Okay, thank you. Rommel?
Sorry, just to pick up, Diane, the fit and proper persons policy at the Audit Committee, we did ask that this be extended to cover not just non-execs, but actually a whole host of interims and contractors that we have at senior levels, and actually that the due diligence checks that our agencies who we are partnering with are actually being undertaken. So that there was an outstanding action which is captured, which I didn't see covered in this note.
So that's a very interesting point. Diane, do you want to respond to that?
Yeah, so it's a piece of work that we need to work with executive colleagues to make sure that we've got the contractors identified and people working externally. I think it will be an addendum to this, and we will bring that back if that's okay.
So things like...
I had
Yes.
taken it that it was covered under 2.1 because it does talk about any other person who performs the functions of a
But maybe people aren't clear
Director.
enough. So,
Yeah.
for example, are all the people working who come anywhere near the site fit and proper person for child safeguarding? Have they got, whatever it is we've all got, I don't know what it's called.
So I think we're muddling up two things.
Okay, go on, Daniel.
So I think the fit and proper person thing applies to the roles that are in 2.1, and
Yes.
anyone who is performing those roles has to comply, whether they're a permanent person
Interim or not.
interim or not. That's the point Lorraine is making.
Yes.
Yeah.
The point you're making is a broader thing, which is so safeguarding, convictions, all of that. We have to check for everybody, but that's different to the fit and proper person's set of...
Okay, and I think that's what Ron was talking about, aren't you? You're thinking of contractors, not just... Or are you meaning that if, supposing we were having a interim chief operating officer coming in from outside, it would include that person? But I think it does, doesn't it?
It does. Well, that's
as written.
The roles set out in 2.1.
So were you thinking all these wider contractors?
I was actually going a bit broader because there have been counter-fraud cases that have come to my notice which highlighted this as an issue. So it's not just senior people that you might list out in 2.1. It's actually people who have positions of authority that might be further down the organisation, and that's an issue
But
that
I
other
don't think they've
organisations
got...
have faced.
Damien, come in.
I might take this as an action, but in terms of agency staff, they would have to come from a specific framework which would have these safeguards built in place. Now, if you go outside the framework, that's where the risk comes. I think it might be helpful if I come back with what the framework safeguards are,
Yes.
so people will be aware
That's
of that.
helpful.
But it's critically important to stick within the framework for this
Right.
very reason.
So I think there are two things. I think we are approving the fit and proper person as read for now, and you will come back, Damien, very helpfully with the framework for contracts and what's in and what's out and where any risks might sit and what we do about those. That's helpful clarification. Thank you. Diane, back to you.
Yes, I think that's it, really, around just to agree the reviewed update policies, please, from board.
Bob's saying yes. Does anybody want to say no? Are we? Mark, you saying yes? Sorry, I saw a hand. Yes, thank you.
Great.
It was quick and I didn't quite catch it, but I did the second time. Okay, excellent. We're approving them.
Thank you. Thank you, Chair.
And just to the exec, please do look at those policies. Are they really policies or should they be procedures? Because you're scoring collectively own goals on keeping things up to date. Less policies, more procedures. Yep.
Yes.
Thank you very much.
So I do think it's really helpful in the policies for policies policy. It does say which committee is responsible for which policy.
Yes.
So I think that's really helpful for everyone to know.
Yeah.
And when we go back to I can't remember now from when I read it last week, if we go to the subcommittees, it's got the policies in it that they're responsible for, has it?
Yes, it is.
Yeah.
Yes.
Thank you. Good.
Yeah.
Excellent.
And can I just say thank you to James on
done,
all of his
James.
work on this before I joined, so thank you.
Very well done, because it is necessary. And I think there is a communication thing, Anthony, about everybody wants a policy when it's a procedure, and how we get that over to staff is going to need some work, I think. Because in uniform services, I think people hide behind a policy when we need to get the message across. It's an empowered organisation, so policies are for really important things, and we need to empower our managers. Thank you. And I'm sure the exec team will help you on that. So it's an ask, exec team, in case you didn't pick it up. You can't do it on this end. Thank you. Right, that takes us to the Board Assurance Framework and Corporate Risk Register, item 12.
Thank you, Chair. So the paper shows the Board Assurance Framework and Corporate Risk Register. There have been no real movements in the level of risk, which were considered by directors and the relevant committees since the last board meeting. These are shown on page 1. Updates are shown in red font, and any questions can be taken by the executive lead for each BAF risk. 2 new risks have been included onto the Trust Risk Register following review by the Risk Compliance and Assurance Group, which are the capability of being able to manage 2 simultaneous significant or major incidents due to Special Operations Centre unavailability, and that risk was scored at 15. And then the number of corporate policies overdue, which was scored at a risk rate of 9. But I'm hoping that both of these will be able to be mitigated quite quickly. and moved on the school.
So I suppose the question is, every time somebody says hope, my mum is in my mind saying to me, hope is not a strategy, and we've used hope quite a lot in this meeting. I think you've got a plan to bring that down, haven't you?
Oh, definitely.
You've got a time scale for doing that.
Yeah. So the timescale for bringing down the out-of-date policies, they regularly go through executive committee now for approval, and it's really around just the time of the governance arrangement. So I think by beginning of next year, I'm looking at James as well, just for some comfort there, I think we'll be pretty much back in the green on all of the policies, which is a huge piece of work, but it's really effective work from the executive colleagues, so thank you.
And just to be clear, do we have any risks on the risk register that exceed the risk tolerance that we gave it? I don't think there are there? But James, do you know that?
It was...
you know, if we've given
John, you've looked at this because it's only just come across to me, so...
It's only just come across to you. I don't think there are. I did read it
Don't
all
think
and
there
I
is,
couldn't
no.
spot any, but I thought people with sharper eyes than me. John?
I don't think
Chair, I think all of the
there's
BAF
one-
risks exceed our risk
are
tolerance.
above the
I was
target.
going to, I'm on the
Yeah.
risk register and I'll come back to the BAF.
Are you
So,
on the
yeah.
corporate risk register?
Yes.
So they're above target, but they're not. Yeah, they're as cited.
But I think that's what, in reviewing all of this, we need to be clear on.
Yeah.
Should we go to the actual BAF risks? 16 seems a convenient number to me. I'm not sure. And we have an at-risk appetite statement, which I think is clear.
Yeah.
It's whether the BAF risks have changed. I've got a clear idea in my head what they are, so I'd just like to rehearse that with people. Karim?
Yeah, I was just going to comment on the BAF that reading these risks doesn't really seem to paint a picture of the risk that the organisation is facing.
Yes.
And I wondered whether...
They need rewriting.
Yeah, I mean, some of them are encapsulated a bit in things like workforce and national uncertainty around funding, but there's a wider or bigger risk, I think, about, demand that we're seeing being permanent.
Yep.
And what that means for people funding clinical quality. Don't get the feeling of that system risk from reading our BAF.
So, sorry, Diane, So I think that because we have been working on a pandemic and things have been evolving, people have been adding, and now is the time to say, okay, workforce is a key risk. Meeting our demand is a key risk. Having the resources to do it and therefore provide quality care is a clear risk. And if I added a fourth, it would be our resilience on IT and telephony, or is that a fifth? But those would be it from my perspective, and I don't think we currently have it with enough clarity. And just talk about how we're going to do that, Diane. Is that part of the review we're doing with the Good Governance Institute or separately?
I think that's more going to be a separate piece of work,
Okay.
working with executive colleagues and committees.
But I think it's then you bulk everything up into those areas. You might have other ones, and that's for us to debate as a board, but I think broadly those are it, and how they do come together to address it and impact on quality.
Yeah.
Yep. So what is the time scale? Lynn, you wanted to come in?
Yes, so Chair, indeed, for me, reading this, I mean, the report is so red that it's a risk by itself, and the change in risk score is so static. So I fully agree that a focused review is definitely needed. Hopefully now that we have a bit more time.
I don't think we do have more time because it's still phenomenal pressure for the executive. So let's see, what is a realistic... Daniel, have you formed a view yet of what the top BAF risks are?
Well, I would pretty much echo what you've just said. But to get to that...
We've got to articulate, change the
It does
paper
actually require a huge piece of work. So I think we need to understand what is our appetite mid-year for doing it, or whether what we want to do is get it right for the next financial year properly and work out what the short-term things are we can do to make it look more right now. But
Okay, so what matters to me is that we've got a risk appetite statement, that we agree that those are the top BAF risks, and that we can, if somebody came and asked you what are the BAF risks, we could all say the same thing. And then when you look at the risk register, are they there, even though we are recognising that over the next few months we need to do that bit of work to re-articulate them, which will, in itself, we will know about the demands, whether it's going to go down or come up. We will know whether we've got the funding. Workforce will remain right up there. And I think our resilience on IT infrastructure will probably, pardon?
Should improve.
Should improve, but it will still stay there. I think it can't go away yet. And then they need re-ranking. So, and it's not really something somebody external can do, because you have to do it in your own areas and look at it. You could do some of it through the subcommittee structure of looking at it. I mean, how you want, it's how you articulate it in a clear way that the organisation would know, I think, is the issue. Karen?
I mean, a middle road may be to add a risk for now that says there is a wider system risk around demand and things, and then take it into account. I mean, I would be uncomfortable with not having the demand risk on the BAF,
Yeah.
because it's a system risk that we need to recognise in case bad things happen. But you know, if we can't do the full piece of work, then you know, at least put that on.
But we could ask the executive just to re-articulate a couple of those risks, be clear of what they are and make sure it's there, because there is a National Health Service risk at the moment around demand and the system's ability across the country to respond to the emergency and urgent from primary care. So we need to articulate that. It's shifting around a bit without doing the major bit of work. Could you do that, Daniel? Do you think?
So I think what Karim just said was very sensible, and that would be a good interim step. Because I think the bigger piece of work is what is our board assurance framework.
Yeah.
We're trying to do a whole heap of risks against something which I'm not clear how we have articulated the framework in the first place. So that's why I think it's a bigger piece of work, which is why I think Karim's point is really sensible.
So let's just, for the purpose of the minutes, James, then, we have a risk about workforce. We have a risk around finance to enable us to deliver. We have a risk about quality, which is, and the question is whether the quality is because of that, is the demand, or whether you want to do, there's a National Health Service risk.
So the risk is not able to deliver the standards of care because we don't have enough workforce and because the demand is so high. Yeah. That's how to articulate it.
Because the system demand has changed.
Yeah.
So what I suggest we get Daniel to do, working with Diane and James, is to write those risks down with that new one to say, are they our new interim BAF? Diane, would that suit your
that's absolutely fine.
And then give us a timescale for the piece of work that can come back, as you say, to re-inform probably by the beginning of the financial year or February sort of time. Is that appropriate? Are people content with that? Yep.
Heather, just to add, I think I agree with that. I think, and it might be obvious to everybody, but it's not clear to me. Perhaps as part of the new framework, we could be really clear on who is the owner of each risk.
Yes. Yeah. No, that's
it's not clear to me.
Yeah. Yeah. I'm not so convinced it's such a large piece of work, because we've just done that in another organisation I work in, and we did it with the internal auditors. But take it away, if we've got an interim that we recognise that wider system risk, gets us somewhere. But I think that I'd urge you to see if it has to be as major as you were saying. And we probably need a board away day to talk about it. Yep.
That'd be helpful.
Okay, thank you. But owners are important, Jill, you're right. Sheila?
One of the things we discussed at the Logistics and Infrastructure Committee meeting was just in the context of the risks as they are currently outlined and the action plan, that the action plan would be helpful. I mean, there's a lot of actions that are complete and there's some red remarks. I think reviewing the actions more clearly, you know, let's remove the ones that are complete. Let's surface more, you know, more easily the really critical action items that are still outstanding, maybe have fallen behind. Because I think we sort of see this report and it sort of gets longer and longer because, you know, there are a lot of actions that are done and then you sort of lose the ability to really pull out the key points. So it was one of the things we asked for is if could the actions be reviewed.
I think that's an extremely important part, because most organisations put it there and then they keep monitoring to death, really, rather than updating it.
Yeah.
So if we can take any off would be good, and we ought to really be able to get more to amber. The financial risk should be getting to amber, I would have thought, when we get our settlement. But the demand is going to stay a high risk. And like, you know, if you go into the helicopter, you'd say demand and having the workforce are going to be the major ones, aren't they?
Yeah.
Okay. Are we clear, Daniel? Diane?
Yes, thank you, Chair.
Okay, thank you very much. Right, so does that bring us to, okay, is there any other business, or as our previous boss said, any pertinent other business, but any other business I will take at the moment? Anybody in the room? No. Anybody online? No. So two things to say. Firstly, to say to Kadir again, many thanks for what you've done for the organisation, and we will watch with interest, and we'll be watching to see how swiftly you return to the NHS.
That's setting you up for success.
And that's not to say he won't be successful where he goes, but he'll realise what a privilege it is to work in the National Health Service, and that he has a great contribution to make in the future within it. So
Thank you, Chair.
thank you again. And then lastly, to say that this brings us then to the end of the meeting in public. And if people were sitting here as our audience, but the online audience who are not members of the board, it's now time for me to ask those people to leave, members of the public and members of the press, due to the confidential nature of the business to be transacted, which, if done publicly, would be prejudicial to the public interest. So I'd like to thank everybody for attending, and for those on the board, see you in Part B later. Thank you. And anybody else, the APM, the annual general meeting or annual public meeting starts at 5:30 p.m. Do join us. Thank you.